one much more engaging. Woo! Keynote. Yeah. All right. Let's welcome Associate Professor Antoine Boivin, who will share with us about learning together to care with each other, how research partnerships can transform health relationships. And Prof. Antoine is the practicing physician and co-director of the Canada Research Chair in Partnership with Patients and Communities at the University of Montreal. And for more than 20 years, he has been caring, teaching, and doing research with patients, families, and community members. And if I remember correctly, it is your first time in Singapore? First time in Singapore. All right. Let's give him a warm welcome.
Thank you very much. And hopefully it's not the last time. I already fell in love with this country and its people. I'm Antoine. In one line, I'm a participatory musician, a participatory physician, and a participatory researcher. And the connecting line is that I love people and relationship. That's what I do in life. I'm driven by curiosity to discover human beings and all our differences and vulnerabilities. That's why I care. That's why I do research. And that's why I love to work with patients. That's all I'm going to say about myself. What I'd like to tell you about, if that can work, where do I point? Oh, this way? This way? Okay. What I would like to tell you about is my partner, Ghislaine. So Ghislaine is 77-year-old. We met 10 years ago. She was born with 2 genetic diseases, survived 3 major cancer, lost her daughter at the age of 20 from cystic fibrosis. She wanted to become a neurosurgeon, but after first year of medical school, because of a medical error, she went into 6 months of palliative care coma. Before the coma, she spoke 7 languages. After, she didn't speak any. She had to start from scratch. At the age of 3, Ghislaine made a promise to herself that she would never be a victim, that no matter if you don't choose where you're born or whether you're sick or healthy, you always have a choice about how you live your life. And that's what she decided to do, to keep moving. And naturally, because of her natural love for other people, when she would be hospitalized, she would naturally turn to the other patient in the room and ask about how they are, listen to them, guide them, orient them in the healthcare system, which is so strange. She started working on cancer treatment team and listened to patients wondering whether or not they should have chemotherapy. Because she was comfortable with death, she started accompanying people at their end of life. And so when we met, she had been accompanying other patients for 50 years like this, informally. I met Ghislaine. She was a teacher in the medical school, a patient teacher, and I was the observer, the silent observer in the room. I had been doing research on patient engagement for a number of years, and I was curious to see what happened when the patients were not the teaching subjects, but they were the teachers. And I saw Ghislaine and I fell in love. I had a crush on her. I invited her for a date. We had coffee, and it was love at first sight. It felt like it was the right hand meeting the left hand, that I had learned to care for people by going to school and reading books, and she had learned to care for herself and to care for others through life's experiences and suffering. She had turned suffering into wisdom and knowledge. And so we had a dream, the two of us, to care together for other people. We didn't know how we would do this, but we felt this was important, and we just decided to try. And what we became is a sort of a butterfly with 2 wings, the wing of professional knowledge and the wing of lived experience and a common heart and passion. So this is the Canadian monarchs. They're really tiny living species that do extraordinary things. Monarchs, every year, they travel 10,000 kilometers from Canada to Mexico and back. They don't travel like planes in a direct line. It's very wandering and exploratory. And they achieved this incredible achievement by doing this across generations. So one generation of butterfly flies all the way north to south, lay eggs, die, and then the next generation pick it forward. And so that's what we've been starting to do. It's a slow journey of exploration and in discovery, in learning to care with one another. So I integrated Ghislaine in our clinic as a full healthcare team member. And we started caring for patients together. And there were some small miracles that happened. One of the first patients that we cared together, I had never seen her. She was registered under my name, but all I knew about her was that she was repeatedly hospitalized and seen in the emergency room for uncontrolled diabetes and heart failure. I tried to call her. I offered to visit her at home. I offered to refer her to the social worker, the psychologist, the nurse, the pharmacist. She didn't want any of this. One day she came to the clinic and I told her, I would like to introduce you to somebody I trust and who I think could help you. And I left her in the room with Ghislaine. And Ghislaine said, I'm not a healthcare professional. I am just a patient. And I would like to know who you are and what you need. And then it's like the dam opened up. And this woman revealed that she was living in extreme poverty. She didn't have food on the table. She was ashamed of where she lived, and that's why she didn't want me to come. She had issues with childcare services before, and so for her, a social worker was a threat rather than help. And so slowly, they started building trust together. And after a little while, Ghislaine said, I would like to introduce you to a physician that I trust and who I think could help you. And we organized a meeting together with her, with Ghislaine and her kids, and we started talking to one another, learning from each other, learning about her life goals. Her goal in life was to see her granddaughter get older. That was her goal, not to get her blood sugar level at perfect level. And so we started setting up a plan to help her achieve her goal. We started with food services, clothes for her kids, and then she from a difficult patient, she became my best patient. So she started texting me when she had questions. We built trust. She started accepting home care, all of this. And so we've calculated that within a few weeks of relationship with Ghislaine, she stopped going altogether to the emergency room and the hospital, and we calculated that Ghislaine alone had saved $15,000 per year to the healthcare system just in terms of reduced hospitalizations and emergency room. Now, in 20 years of practice, I had never seen something with such meaningful and important impact. I decided to switch my whole research program in that direction and to do research with Ghislaine because she knew how to do this. I didn't know how she did it, but I knew that it mattered and it was really important. So we started becoming research partner. Now, Ghislaine, she doesn't have a university diploma. She didn't know about research, but she has the curiosity mind. She's curious to learn, to discover, to explore. She has the scientific mind. And so we started doing research, trying to open the black box of what's going on there. What is she doing? And suddenly, we also started teaching together. I started getting all these invitations. Dr. Antoine, can you come tell us? I said, yes, to the conditions that it's the two of us talking. And so we gave over 80 scientific presentations together up until meeting the Minister of Health. And slowly, people got used to the idea. Initially, people were quite scared. They said, Antoine, this is crazy. It's dangerous. A patient talking to other patients. What if we get sued? And so research, the first contribution was to create a safe space to try new things, to care together. We said, well, Ghislaine, she's an experimental intervention. There's a consent form, so then we can try at least. And so it gave us the space to try. That was the biggest contribution of research. And then we started leading together. After a couple of years, it became obvious that we were leading this thing together. We were hiring staff together. We were co-supervising master degree and PhD students together. We were teaching medical students together. She was the co-director, in fact, but I was the only research chair. And so I said, well, let's put it in Word. And so we didn't ask so much permission, but we named Ghislaine as co-director of a Canada research chair, which was a first in the country and made a big impact. And then other people started approaching us and said, well, can we do this? So we have a young clinician scientist colleague who was really interested. He's working in homelessness. Said, well, let's try. So we found somebody with lived experience of homelessness, Danielle, who lived 5 years in the street, history of schizophrenia, alcoholism, a really good heart. And Ghislaine could sense that he had what it takes to work in the team. And so after 10 years of employment, he started working in a clinical team in December 2020, which was in the heart of the hurricane. It was the second wave of COVID that hit Montreal the hardest. Shelters were blocked. The workers were exhausted. And Daniel started his first day of work after 10 years of unemployment during that period, cold winter, Canadian winter. And so the team was really worried, he's had mental health problem. What's going to happen with him? He's going to be stable. And so the research team was following. And after a month, we asked, Daniel, how are you doing? He had a huge smile on his face. I'm doing great. What I've learned over the years, I'm putting it into service of other people. It's fantastic. And I've started doing cross-country skiing. And beside him was the medical director, Mathieu. He was green. He hadn't slept. He had worked throughout the holidays. And then Daniel turned to him and said, I think, Mathieu, you should take your weekend off. And so he taught us that what he learned in the streets was that in order to survive, you need to care for yourself first, which is not what we're learned in medical school. We jump in the fire and then wonder if we have an oxygen tank. And so after 6 months, we ran out of research money, and the team said, well, we can't leave with him. We can't let him go. And so they found money, hired him, and now he has a permanent job, and he's been working with them for 4 years. This is the team now. We're working with with a couple of teams who are experimenting with this, with people with lived experience of cancer, serious mental health, addiction, homelessness, migrants with precarious status, indigenous people, working with physicians, nurses, psychologists, with researchers in health and social sciences, community psychology, anthropology. This is the team. This is the combination of different knowledges that make this possible, not only in Canada. Now, we're starting to get approached by teams in Europe and Asia who want to try this in their own way. So this is a team I was visiting in Japan who came visit us 4 years ago. Because they were curious. And we haven't exported the model to Japan. In fact, they recognized that we had the same value, and what they were already doing was aligned with the principles of what we're working with, which is simply to recognize the knowledge and the value of people in the community and try to work together. So that's the model. That's what we do. Like what he was sharing, becoming sick or becoming homeless is like falling. And you lose your identity, you lose your purpose, you don't recognize yourself. For some people, it's like you've become the disease. And so what we found, the miracle that Ghislaine was doing, is that her first intervention is not to do anything. It's just to look at the person differently and recognize the person behind, not as a disease patient, but as a person with dreams, with strengths, with possibilities, and then accompany them, walk alongside them to achieve their own life goals, which may be to play the guitar again, to be a dad again. and then connect with other people around who can help them achieve these goals. Sometimes it's in the healthcare team, the social worker, the psychologist, the physician. Sometimes it's outside the healthcare team, in the community, your wife, your kids, your friends, your neighbors. And so this is what it means to create caring community and to recognize that we all need each other to get out of this hole and come out a little further, to learn something, and then have the possibility to accompany other people who face similar struggles. So this is a global journey, and it has started thousands of years ago. We're just rediscovering it. If you read the literature on patient and community engagement, you'll find publications from a long time ago. In the 60s and 70s, what you found were mostly the principles and the concepts. For example, Arnstein ladder of citizen engagement, informing people, consulting with them, participation, partnership, leadership, all of this. The disability movement taught us nothing about us without us. WHO at the time, the Declaration of Alma-Ata said, every member of society has a right and a duty to participate in their own care and in the orientation of health systems. In the 80s and 90s, we moved to case studies. We started experimenting with this in all areas of health. Health technology assessment, clinical practice guideline development, medical education, citizen deliberation juries, policy making, shared decision making, all of this. We started having specialized journal to publish this, health expectation, research involvement, and engagement. This is when I started my research career about 20 years ago. And so you had all these exciting experiences in the UK, in Europe, in Asia, in Africa, community health worker. A lot of the work in low and middle income countries was also based on the integration of community members as part of health promotion programs. But when we were asked, well, what's the hardcore research evidence proving the impact on health outcomes? It was a little shaky, and it was hard to answer these studies, to these questions. And then in the 2010, 2020s, we started appearing these trials. And so when I did my PhD and wanted to convince my medical colleagues, I knew I needed to do real research about this. And so I did a cluster randomized trial on the impact of patient and community engagement in setting priorities at the level of health systems and health organizations. And what we found was the differences were huge. When we presented the results in the control sites, there's a physician in the room, there was dead silence. And a physician stood up and said, our priorities have nothing to do with those of patients and community members. And that physician, she practiced in a community of 3,000 people, which meant that a third of the population were her own patients. And she realized that although she knew these patients, she really didn't know what were their priority. And so she asked, can you come back? And can we get these discussions with patients and community members? And when we just set up a dialogue where everybody's listening to one another, priorities shifted on both sides. And we could agree on common priorities to improve healthcare systems locally. I was invited in 2020 to write an editorial on a meta-analysis on the impact of patient engagement in clinical trials. Now, this was getting really fancy. You had a meta-analysis of trials embedded in large multi-center clinical studies to test the impact of patient engagement on recruitment rates in clinical studies. Now that matters because a single trial in cardiology that can cost about $500 million. And if the recruitment rate is under 80%, the study is scrapped. It doesn't mean anything anymore. And so they found that patient engagement does increase recruitment rates, which meant that, this is also important for the quality of scientific research. And now this is 2024. And in my lifetime, I think What happened in last May at the World Health Assembly was one of the most important international agreement in that field. In May, world leaders from all countries, including Singapore, adopted a resolution on social participation in health, which means recognizing the importance for health systems to partner with people, communities, and civil societies at all levels of health systems, to fund it with public money, to sustain it, and to ensure that people from all walks of life can participate in this. So, which means that we're moving from an era where patient and public engagement is sort of like the cherry on top, the nice little thing that you add to say, well, we've got a really good design study and we had a patient on the team, isn't that cute? That's the cherry on top approach to patient engagement, to the flower in the cake approach to patient and public partnership, to realize that health, if we're concerned about improving health in society, we need to partner with society because 80% of health is produced by society, not by professional health systems. And so what we need to build and do and nurture is the connection between professional healthcare systems, the triangles, hierarchical systems, hospitals, clinics, doctors, and communities, the circle, the natural world where people help one another because they love one another, because of friendship, because of solidarity. So these are two worlds that are essential to create health in society and that we need to bridge. Why is this important now? Well, Sanjay gave some answers. In medical research, we tend to look for the latest study. But sometimes the most important facts are those that have resisted the test of time. Now, this is a study that was published in 2001 in the New England Journal of Medicine by a researcher called Larry Green. And he used the same methodology as that was published 50 years before in 1961 by the father of health services research, Kerr White. And it's called The Ecology of Medical Care. And it says basically that every month, 1 person in 1,000 will be hospitalized in a university hospital. Now, this is where we spend most of our healthcare money. This is where we do the most amazing things and technology. This is where we transplant heart and all of this and do personalized medicine and genetic testing. And it's incredible and it's important. But it's not all the care there is in society. Every month, 100 people in 1,000 see a community physician like me in the clinic for normal conditions and the follow-up of chronic condition. And as family physicians, we tend to see ourselves as primary care, the first line of care. This is where care begins. When I teach medical residents and they see a patient for the first time, they say, "Oh, I'm taking charge of the patient." What do you mean you're taking charge of the patient? So this 83-year-old woman who's been standing on her own 2 feet for all her life, now you're going to carry her on your shoulder? And if you're not there, she's going to die? No, you're going to accompany her. I mean, the first meeting is a discovery of who this person is. Because in the end of the day, even for me as a physician, as a family physician, I see people for a few minutes every year, maybe 1 or 2 hours at most. The 9,000 other hours, they're spent in the communities at home. And so this 1,000 people in the community every month, 80% of them present with health symptoms. And the majority of them never see the healthcare system. They care for themselves by themselves with the help of people around them and community members. This is where most of the care happens, but this is largely invisible. When we think of health systems, we think of icebergs. We only see the visible tip of the iceberg, and we forget the hidden bulk of care and health that is produced in communities. And when we forget that, it can lead to catastrophes. We've heard about the problems of our healthcare system: lack of funding, exhausted workforce, change in aging population, pandemics, climate change. Now, if we see ourselves as physicians and healthcare institutions as the saviors, and patients and community members as poor little people that we need to take on our shoulders, of course we're going to crash. But if we flip the narrative, if we start to recognize that people have knowledge, they have resources, they have strength, they can overcome challenges, and we can work with them as partners, then we can start creating health for everybody, with everybody. Now, what does it take? Who do we need to make this connection between health systems and communities? You don't need a statistically representative patient around the table, just like you don't need a statistically representative anthropologist or epidemiologist on the research team, okay? You need somebody who has project relevant knowledge. What is it that we want to do together? And who has the right knowledge to contribute? You need people with humility and curiosity, people who know that they know something, but also know that they don't know everything, so that they will partner and be open to listen and learn from each other. You're often looking for people with in-between journeys, people who have navigated between both worlds. And patients do navigate between both worlds, especially when they live through the healthcare system and in communities, and that's why they can help us connect the dots. Health professionals who have become sick also can be bridgers and translators and ambassadors between these two worlds. And you need shared passion. You work together because you want to improve things together. And where should you start? For me, it's very simple. At the end of the day, this is just about transforming the type of relationships that we have with one another. And in 20 years, I've found that the most powerful question to do this is to sit down with somebody, look them in the eyes, and ask them, who are you really? And listen. And discover the person behind, and discover what we share in common, and start our journey together. Thank you.
Thank you, Prof. Antoine, for your inspiring address. Now, can we have back on stage, please take a seat as well. We will have our moderator, Prof. Joanne, join us. Now, please remember there's going to be a QR code where you can input your questions, but given that this is a small, cozy room, please just stick your hand up and a mic will find its way to you. All right, QR code here for any of you a little bit more shy.
Okay, so hopefully we're going to have some questions coming through. But while we're waiting for that, Antoine, how do we find more Ghislaines, and what do we need to do to support people to be able to take on such an active role if we don't have to wait for them to have 50 years of experience first? So what do you recommend there?
Yeah, that's funny. That's a question we've been asked so many times. How can you clone Ghislaine? And Ghislaine's answer to this is there's no need for cloning. We need to recognize the Ghislaine that already exists in our communities. Now, here's the trick. The people who listen best are also tend to be the people who speak the lowest. And so we need to pay attention. Who are the natural caregivers in society? Who is it that people naturally turn to when they don't do well? Who is it that everybody knows? Even in homelessness, we were talking with our colleague Daniel, and he said, in shelters, there's this guy or this woman that people tend to go to, to find information. Where do you find support? All of this. Some people have it. She always said, you have it or you don't. And so there's natural competencies and personal attitudes and attitudes of hearts that people have and that make them suitable for different roles in the health ecosystem. Now, there are different roles. You know, if you want to be a patient educator, obviously you'll need on top of this communication skills. If you want a patient researcher, you're seeking people with curiosity. Now, when I'm approached by some patient partners and they say, oh, I want to do research, I want to prove that this is true, that's not the scientific attitude. When I have people say, I'm curious and I'd like to try something new and explore and discover, Ghislaine, you know, she's 77. She's afraid of dying not because of death, but because she's so curious to see what else is there to come. Now, she's really driven by curiosity and empathy when we're talking about people working in healthcare team. It's the natural listeners. So it's finding the natural talents.
So we've got some questions coming through now, and I know that we've got one in the audience as well. But this is a question that we've come up across in some of our workshops that we've conducted with Open. And so one of these questions are, how do we break through the fears and concerns of healthcare professionals about engaging with patients and caregivers, the fear of showing vulnerability, and also the question of the legal liability? So how do we get health professionals to feel confident about engaging with patients in a deep and meaningful way, like you've talked about?
So I think what is useful, two things. The first thing is that we need to think about what a partnership space looks like. That sounds a little theoretical, but let me explain. In a clinical space, physicians expect of themselves, oftentimes it's not the patient expecting them, but they expect of themselves to have all the answers. So they position themselves in the teaching role rather than the listening role. Now, when you create a partnership space like we have here, or we're going to have tomorrow as a workshop, we create an environment that is set up where the rules are different and where, for example, everybody's going to be addressed by their first name. Or you're going to leave time to share about something that we all have in common. You know, what's your favorite food? What's your favorite song? And what do you like in life? Rather than what differentiates us. So create opportunities to connect beyond the differences. And then the second thing, so that's the partnership space. The second thing is the partnership capacities and attitudes. This is not for everybody. Some health professionals have it naturally, okay? You have it. Sanjay, you have it. I know it, okay? And you know it when you see it. So it's, Jonty, you have it too. So it's those professionals who tend to position themselves with a little more humility, who are really listening, who are curious, willing to engage in different spaces. These are the people you want to start with, the early adopters, okay? And they are the ones who are going to open the door for others to follow. So it's not only about preparing the patients to enter university, but it's also about preparing the professionals, the teachers, the researchers into entering into partnerships. So everybody needs to be accompanied there. And it's okay to be afraid because it's a different kind of relationship that we're not used to.
Okay, so we've got a question from the audience.
Hi, thank you very much and good morning, Antoine and Joanne. Hi, I'm Clive. I'm a medical practitioner. So this question is for the in-flight medical practitioners, because 20 years ago we graduated from med school, and the teaching at that time was still very provider-centric. I can recall going to the wards and saying, the patient in bed 63 is going to go for operation. The patient in bed 47 needs an X-ray, and often we don't even mention their names, right? So while we are changing the medical education and for our nurses and our doctors, what advice do you have for the in-flight folks, right? To start to be able to see patients as people with stories like Candy, right? She's Candy first, then a patient with diabetes, right? Yeah. So how do we do that? Thanks.
For medical students, you mean?
in-flight healthcare professionals.
What is that?
Are ones that are already working in the field and haven't been maybe trained from this
Oh.
perspective. Yeah.
Well, I'm just thinking out loud of certain really small things, and you probably already do this in some settings. I remember visiting a long-term care facility of people with dementia, and the simple fact of putting a picture of them in, from before, it reminds you of the person who's there. Um, you know, saying hello, simple things, and really it doesn't take much. In my experience, the most powerful change agent is try it. And so I was telling you about my colleague Danielle. It's when we did the experiment with them, with that team, we didn't even have time to write the research paper. So it's not the research evidence that changed professionals' attitude. It's the fact that for a few weeks, they had the opportunity to work with a person who had experienced homelessness, not as a client, but as a colleague. And that transformed my view of homelessness and their attitude towards it. So what we're experiencing today, hearing the story, having Wadi sing on stage, I think that's pretty transformative stuff. So it's for me, the changes, it comes from the heart, actually. Not much from the head. It's not much about, teaching cognitive-based curriculum about the concepts of patient engagement, but experiencing it. That's what's most transformative. One thing I want to say is that you're already doing this. And I was really, really struck in Singapore about how much of a culture of community engagement there is here. You see events happening everywhere. It is a community-driven society that you have here. The other thing that you have here, it's a culture that is a society that is used to looking at the world from different viewpoints, that is multicultural in nature, and that creates natural abilities to see the world from multiple perspectives. I think Singapore has huge assets to advance the world in this domain.
Great. I'm going to ask another question that kind of links a couple of these together. What can we do from maybe a researcher or a healthcare institution perspective to really not be tokenistic if we have people that are being brave in what I can see from some of the questions can be quite a hierarchy sometimes between the doctor and the patient. How can we avoid saying the words but actually carrying through with the action? How can we create a more equal playing field where the patients are also acknowledged as experts in their own condition?
My main advice is take time to nurture relationships. One of the key killer of effective engagement and partnership is try to rush projects and have big impacts, or in such a pre-planned way that it doesn't allow for real input. And so that's why I told you about the butterflies. It's going somewhere. It knows where it's going, but the path is going to be discovered along the way. And so one of the main structural barriers we face in research is that oftentimes people, to get funded, you need a detailed research protocol, and it's planned to the comma, and then patient comes in and you cannot change anything. So that's a barrier. Or the funding application is sent, is open a week before, and then it says, well, co-design your project with patients. Well, how do you have time to build a relationship and brainstorm on the project together? So one thing that has been helpful for funders is to have engagement grants, which are about funding the relationship building process that will lead to a project that is itself co-built together. So you are funding protected time to build relationships and develop a project together. also it's embedded flexibility in the project, because you may have 2 or 3 or 5 patients around the table, but when the project will land, then you will need meet communities, and you will need to shift and be flexible. So the project in homelessness, it was a success because we were working with a funding organization that allowed us to be flexible in how we work. We were working in the pandemic. Everything was changing all the time. But it's that flexibility, and this time we extended, we had a no-cost extension to this project that allowed us to take the time to do it right, and that's what led to success.
So a theme that's also coming through some of the questions relates to time, and how do we shift the narrative when we've got, say, primary care doctors that need to see a certain amount of patients in an hour, to give people that time, to give the hospital and the administrators also time to co-create some of these things. How do we create the opportunities and time?
Well, it's funny, this has saved me so much time working with Ghislaine. It took some time initially, but once it started, I mean, if you're in medical practice, if you're a health professional, you spend a small amount of your time on the real medical stuff, the stuff you've been trained on. And then, I mean, health is largely about psychosocial struggle, of living with the illness in daily life. And then if people only have the option of seeing a doctor about this, then of course you don't have time, and you don't have the expertise, because you know about the disease, but you don't know what it means on a day-to-day life to deal about it. And so incorporating a partner who knows about this stuff and say, well, let me introduce you to somebody I trust and who I believe could help you, suddenly the patients who were kept on coming to me over and over, my elderly patient with loss of autonomy who was struggling to accept this, the woman with sexual trauma who was struggling with the post-op of her mastectomy, and all the crisis in identity and lived trauma and all of this, and all of these issues that are social issues with medical symptoms. And it's okay that it lands in the physician's office, but we need to extend a hand and work with other people to address these issues. And sometimes the patient partners or the peer on the team offer this bridge with broader resources in communities, but also in the person himself or herself to address these things.
So there's a question here from somebody, so one of the patients in the audience, and they've been living with their a caregiver and also with arthritis, a parent with rheumatoid arthritis for 30 years. And the journey's been challenging. So the question is, how can the public or the word here is the common folks, but I think everybody is special and individual, but how can they come together and have the opportunity to work with health systems to work better, because they've got all of this experience? You met Ghislaine by chance. Yeah. How can we make it so that these opportunities are maybe more available for people? It doesn't rely just on chance. Is there any examples maybe from Canada or around the world where you visited where people have been able to come together really effectively and generate some great outcomes?
We were talking about this a little yesterday, but I think, again, the idea is to tap into existing relationships that exist naturally in communities. So we tend to think of population as all disconnected people, but there's existing connections between all of those. Yesterday, Ritu was saying the best way to find, or was it you, or the best way to find 10 patients with this condition is to find 1 or 2, and then they know others. You've told me about, finding friends, with diabetes, and others, and there are communities. Sometimes it's structured, sometimes it's very informal. Facebook group, Instagram, community events, and all of this. And so you need in this ecosystem people who are bridgers, those who are bilingual, like you, or like Aileen, who know the patient language and the professional language. But you also need the connectors, those people who know other people, the patient who know 10 other patients. And we need to work with these people to extend the connection, to work on what already exists in communities in terms of relationship. I mean, when I arrived here on Sunday, there was this event for Diwali. There were 150 people, and I mean, this is a society full of connections that can be tapped into. And so we can partner with all of these things to reach out.
Oh, we've got a question from Chema.
Thank you very much. Excellent presentation and discussion. My name is Jose Maria Chema Valderas. I'm a family physician and professor of medicine at the National University of Singapore. One brief comment and a question. So I've always had some hesitation. Okay, I worked with the Declaration of Astana with WHO. One of the reasons why there was patient and power engagement as one of the three core elements alongside multisectorial action and primary care and public health was because we all believed in that. So it's not an issue of principle.
Yes.
It's actually about finding how to optimize them.
Yes.
With individual patients, there is not, I mean, the alignment is easy because it's a single patient. When you work with communities, communities are a collection of people who also have, to a degree, agenda. And you may be to a degree, also need to incorporate and work with communities and organizations who, to make things perhaps more understandable, perhaps may be very clearly anti-vaccines, or may be proponents of values that may not necessarily promote the independence of the individual patient, or may be against individual liberties. So, it's a matter of fact. People actually express themselves politically in a particular way, and they may choose to organize themselves in such a way. So this long discourse was to say whether you yourself, in your pathway, had encountered problems of this nature, and how you were able to deal with this tension that is. I was waiting for the question to come towards the end, towards the end, because I think that we want to give a positive message, but I think that it's also important to consider risks and potential problems ahead. Thank you.
Thank you very much for raising risks and concerns, because they are there, and everybody, like many people, experience this, and this means that this is a safe enough space that we can voice them. So thank you. Yes, it's challenging, and partnerships, as any relationships, it's not perfect. Okay, it's imperfect, and it comes with conflicts. And conflicts are unavoidable, and they are necessary. So there's this thing about successful partnership is to have constructive conflicts. That's one of the things that you're seeking, is the encounter of different ideas and values that force you to make them explicit, to negotiate them, and see how can we work together or not. We don't have the same, when we talk about, experience-based knowledge versus scientifically based knowledge versus professional experience, it doesn't always align, So we may not agree about the right course of action. It may need negotiations and dialogues. And for me, the nature of a successful, meaningful partnership space or dialogue is a dialogue in which everybody enters with the expectation of a slight change in their position by the end of the dialogue. This means that this was a true dialogue. It means there was a bit of mutual learning, mutual influence on one side and the other. This is different, a partnership space, from a ring where you expect someone to win or to lose. Okay? So partnership is about dialogue and listening on both sides.
Now, I know that there's some questions that we haven't got to, but the good news is we do have some other sessions coming up where I think we'll be able to answer some of these really well. So issues around remuneration for people's time, how to get funding maybe in more non-traditional, non-grant ways so that you can be able to engage in a meaningful way. So I'm sure those will also form the discussion that we have. But I just want to thank you, Antoine, for your talk and
Thank
for
you so
everybody
much.
that's participated in the questions.
Thank you.